Welcome to Brain Wellness, the podcast. I'm your host, Mandy NP. What started as all things related to brain health and wellness has morphed into largely brain injury health and wellness, with occasional other neurological topics. My mission remains the same, to help you on the path to a healthier brain. So, without further ado, let's get into the show. Hello, everyone, and welcome to another episode of Brain Wellness, the podcast. My guest today is Dr. Stephen Broglio. Dr. Broglio has investigated concussion and mild traumatic brain injury for more than 3 decades, holding faculty positions at the University of Michigan and the School of Kinesiology, along with joint appointments in neurology and physical medicine and rehab. Following his doctoral studies at the University of Georgia, Dr. Broglio established his research portfolio focused on the acute and persistent consequences of head trauma in athletes and military personnel. He currently holds multiple administrative roles, including the Associate Dean of Graduate Affairs for the School of Kinesiology and the founding director of the Michigan Concussion Center. In his directorial capacity, he heads collaborative, multi-disciplinary science aimed at advancing fundamental understanding in concussion prevention, accurate diagnosis, and optimal management strategies. His academic record is underscored by his status as a fellow in multiple professional organizations, which I will list in the show notes, and he currently serves as the president of the International Concussion and Sports Group. Thank you so much for being here today, Dr. Broglio.
Thank you so much for having me. I'm excited to have this conversation.
Yeah. It was so nice to actually get to see you in person at the Minnesota Brain Injury Alliance conference recently as well. And we've been connected on LinkedIn for a while and following all the stuff that you're doing in sports. So it was nice to see you in person.
Yeah, you as well.
So my first question to my guests is always kind of what got you to where you are? And we got your bio, we know your background, but what got you interested in this to begin with?
Yeah, it's a great question. So I did my undergraduate training at the University of North Carolina, and my advisor there, I was in the athletic training program, so he was the program director, but my advisor was this young upstart faculty member called Kevin Guskowitz, who was a second-year faculty member who clearly had it all put together and figured out at that point in life. And for those who don't know, Kevin then went on to become a Time 30 Under 30 named individual for his work in concussion, became a MacArthur Genius Award winner, and then was chancellor at the University of North Carolina, and then most recently president at Michigan State University. So very smart guy, super nice guy, and very willing to take time to educate sort of that next generation. And I lucked into it, to be quite honest. And he was in the concussion space, and I started basically hanging out in the lab, and I was doing data entry, which led to running participants, which led to running my own research project as a senior student. And then that sort of got the ball rolling, and I did my master's degree at the University of Pittsburgh, and a doctorate at Georgia, and then took my first faculty position at Illinois in 2006, and then I came to Michigan in 2000. So it's just sort of grown really from that initial sitting down in front of a computer and a blank spreadsheet, entering data, back in like 1998, 99, in that neighborhood.
Funny. Yeah, that's about when I started in healthcare, and I did not know I was going to be in concussion at that point.
Yeah.
I was general neurology, but it was not so much concussion focused until my own injury, which that's kind of what sparked most of what I do these days. But why athletes? Why sports medicine? What does that get us?
So I think my personal story was I was in school for a little bit and then out of school for a little bit before I went to North Carolina, and during that kind of out of school period, I did some shadowing in a PT clinic, and then with some athletic trainers. A friend of mine connected me with some practicing athletic trainers, and I like the environment. There's some glamour to it, I will admit, and it just really appealed to me. And so I think that's where I decided to get the athletic training degree and kind of go that way. I think that was sort of what drew me into it. But I think as I got into it, what I realized is if you're going to study a population like athletes, you have a known injury incidence rate, particularly around contact collision sports like football, hockey, and lacrosse, wrestling. So it's very easy, or easier, I should say, to do baseline evaluations on those individuals and then do post-injury testing to sort of see, kind of get the pre and the post, and then kind of go from there. If you do that in the general population, it's virtually impossible to baseline test the world or a city or a university for that matter, and then wait for injuries to happen. So it sort of becomes this very nice model for studying concussion. It doesn't, everything we learn in athletes doesn't directly apply to the general population, but there are a lot of lessons learned or guidance on how we can manage those individuals. So it's been a nice way to start, but it's definitely not the end point of where we need to go.
Yeah. So I'd like to think that people know all of the data on concussions, but I don't think people really do. Are all sports the same as far as concussion risk and what we need to monitor?
Certainly not for risk. So our contact collision sports are going to be our highest risk. And so football, ice hockey, wrestling, lacrosse to the top of the list. They tend to be male sports. On the female side, women's soccer tends to be very high. And it's been a bit since I looked at the data, but I believe women's ice hockey is up there, volleyball is up there. But women tend to participate in fewer contact collision sports than men. So that risk tends to shift into the other sport categories for them. But every sport has risk on some level. We have cross-country runners that trip and they hit their head or they get hit by a branch. We get swimmers going backstroke, they hit their head on the wall, or they're doing dry land training or slip on the pool deck. So it can really happen in any sport at any time, but the propensity for it definitely falls into our contact collision sports.
Yeah, yeah. And then one of the biggest things you talked about at our Minnesota Brain Injury Alliance conference was kind of the updated recommendations with sports. Can you share some of those with our listeners?
Sure. And so right now, obviously, if we suspect concussion, we want to remove that individual from participation, which eliminates further injury. There's good data. I'll credit Bretton Askin. He's a faculty member at University of Florida now. But he was really the first to identify that individuals that continue to play in their sport, whether they get hit in the head again or not, they have protracted recoveries. They 2, 3, 4 days longer than those that are immediately identified and removed. So we want to get those players out. The clinician, if there's one on the sideline, they can do the evaluation and make a determination. So not every time somebody gets hit in the head and we think there's a concussion, there actually is. However, we never want to put an athlete back into play the same day unless they've been evaluated and cleared by a medical provider. So athletic trainer, physician, somebody that has that training. If not, then we're just going to remove and then we'll refer to somebody who does have the training and can do the evaluation. And then we'll let them make the decision as to next steps. Historically, what we would do is then we would shut that athlete down. And that was sort of social isolation, sport isolation. And we want their symptoms to go to zero before they would start to return to play protocol. And we've learned over time that actually is not a good model. So as those concussion symptoms start to come down over days 3, 4, 5, the social isolation, particularly in our young athletes, those symptoms start going up around the same time. So disentangling the concussion symptoms from the social symptoms becomes super complex. So what we now recommend is we want to give relative rest for 48 hours. And that can be, they could do activities of daily living. I would say clean an apartment, but a college student probably is not cleaning their apartment. But if, maybe around the house, if it's an adult, then, they can do things around the house, for instance. Go for a walk, that's fine. So long as it doesn't exacerbate symptoms. Then at the 48-hour mark, then we're going to start a tailored exercise intervention. So we're going to start them at about 50% of their maximum heart rate on an exercise bike. If they tolerate that, we'll go to 70%. The next day, we'll get them into sport-specific drills that put them at no risk for further injury. Right? So this is a soccer player might be kicking a ball or doing a little bit of dribbling, but they're doing it by themselves, right? They're not with the team. As they progress through that, then we can get them back into team activities that are at no risk for contact. And then we get them into contact participation and then ultimately clear them to return to play. The average for the collegiate athlete, the average time to get them back onto the field unrestricted is about 2 weeks, but that's about 50% of the people. So we have really redefined normal concussion recovery is up to 1 month. And that's where we see about 85, 90% of people returning to their sport in an unrestricted manner. That last 10 or so percent, the majority of them will recover within 2 months or 3 months, but there is a small tail of people that go out and beyond that. So overall, I'd say the injury has a very good prognosis. People do recover, get back to what they want. But I would say think about probably up to a month for most people, but then there is this tail of people that have really more challenging injuries that might go down.
Yeah. And you kind of mentioned there historically, we've done things a little bit different. I remember growing up, we were very different in how we identified concussion and what we did. How often are we updating guidelines and should anybody still be thinking in some of those old terms?
Yeah. So I would say when you and I started the late 90s, early 2000s, the guidelines, there were very few. And so I think in 2001, the Journal of Athletic Training published a paper that listed all the current guidelines at that time. And I think there were 6 or 8 different guidelines, ranked them rated injuries, 1 to 3, 1 to 6, 1 to 8 in some cases, very heavily based on loss of consciousness. I would say now we have definitely eliminated the grading. There is no mild, moderate, severe concussion. There is no 1, 2, 3 concussion. There's no good concussion, bad concussion. It's just concussion. And that has largely been in part because of the concussion with sport group. So starting around the 2002 Winter Games, I think I have that date correctly, a number of the international organizations, so International Ice Hockey, FIFA, World Soccer, World Football, I'm trying to remember some of the other groups that were involved, rugby, maybe equestrian at that time, they came together and they had a consensus meeting to develop a unified concussion protocol. So every 4 years since then, roughly, that group has met, they review the world's literature, and then they update the guidelines based on kind of how the science has changed. There was a delay in 2020 because of COVID, and then I think we're going to be delayed again. We were supposed to meet this year in 2026. So I think it's going to be 28. So there's some delays in there, but roughly every 4 years, those guidelines get updated. And what has sort of happened over time is more and more organizations are adopting those guidelines as sort of the template or the base for their specific guidelines. So I'm an athletic trainer. We just updated our guidelines about 2 years ago, but it was largely based on the International Concussion Sport Group, but we tailor it specific to athletic trainers. Physical therapy has their own guidelines. American Medical Society for Sports Medicine has their own guidelines. So they're tailored to the licensure responsibilities of that profession, but they use the CISG as sort of a template to do that.
Nice. Nice. There were several articles that have come out in the last few years that identified that up to 50% of individuals that have concussion still continue to have symptoms well beyond a year. And you mentioned that kind of 1 month time for athletes is still there. Why do you think there's a big difference between overall concussion and those in athletics?
Yeah, so I think you're talking about more in what we would call the civilian population, right? The
Yeah.
military, the active duty person, or not the athlete, but kind of just, mom and dad, kid type of thing.
Yeah. Yep.
And it's a challenge, and it's a challenge for a number of reasons. One is the injury is not getting identified and managed as quickly as an athlete who has somebody there on the sideline or position. The other is the care that they receive. So you might be in a car crash, you go to the emergency room, emergency department, and they're worried about, do you have any trauma, like life-threatening trauma, right? And that's what they're screening for first. And they may not immediately recognize that the concussion has happened. Or if they do, they may just say, go home, take it easy for a couple of weeks, come back if there's a problem, and not refer you to a specialist, a neurologist or a concussion clinic or somebody that can manage that injury. The other is, they may not even recognize it and just get discharged out into the world. And then if, for the most part, people are in rural environments in the United States and they don't have access for places to go. It can also, we can start overlaying, there's litigation involved. So we talk about the car crash. There's some pretty clearly documented evidence that people that have litigation involved, their symptoms tend to go longer than those that don't. And there can be social or cultural factors that sort of layer on top of these things. So it's a challenge in the civilian world, primarily around medical access and appropriate care. And there have been a lot of changes in the positive direction that have been made, but there's a lot more room to go.
Mm-hmm. Mm-hmm. Yeah. I had the opportunity to tour our Viking Stadium here in Minnesota and see all of the therapies and everything that they have to even prevent concussions from happening. Do those same kind of things happen at collegiate level as well?
I'm not sure about the Vikings. I'll try to speak broadly. What I do know about the NFL versus collegiate level, and I would say for the most part, yes. The NFL is very unique. It's, they can control a lot more of what goes on at the club level than the NCAA can control. But they do, the helmets are up to date at both levels. The NFL is a little bit interesting. They actually only they only allow for one contact practice a week. So they actually do very little hitting outside of games. The NCAA is a little bit different. They eliminated 2-day practices, I think 6 or 7 years ago. I don't remember exactly. But they still have a number of contact practices that happen throughout the season, with the exception of the Ivy League. The Ivy League actually banned contact practices around the same time that the NCAA altered their rules. Obviously you're both levels of player. The skill level is exceptional at both levels, but it is, the NFL, they're at that level for a specific reason because they're very talented at what they do. So there is a little bit of skill that differs between the two. And then when we think about the NCAA, I will think about a school like Michigan. This is where I work, and we have a lot of resources here. But as you get down into the D2, D3 levels, there may not be the same number of resources that are available to those athletes as we would have access to here at a place like Michigan. So I would
Sure.
say similar on some levels between the NFL and the NCAA, but also different at other levels.
Yeah, yeah, yeah. And then what about that person who just does activities on their own? They're not in an organized sport. They are playing pickleball. They're doing some kind of sport on their own and they get an injury. Can we use some of that data from the concussion sports to recommend getting back to sports on their own?
Certainly, I think those guidelines apply pretty broadly. So if you would have a recreational athlete that had the injury, then I think the guidelines that the CISG puts out, I think would apply really well. What I'm less confident is if you had a sedentary person that, let's say, slipped on the ice and had an injury,
Mhm.
because they have never exercised in the past, I'm not sure how well those guidelines would tailor to that individual because I'm not sure how
Yeah,
they would tolerate the exercise would be new to them, and I'm not sure how they would tolerate the new exercise on top of the injury relative to just, I don't know, some other therapy that might be involved. Uh,
right.
I would like to think it would work. You might have to scale down the intensity a little bit because exercise is new to that person. But the idea that exercise is medicine, I think that applies broadly, right? We see that in orthopedics all the time, whether you're an athlete or not. We want people up and moving because we know there are benefits to that. But I don't know the literature or that piece of the literature well enough to say something about the CISG recommendations to a sedentary civilian population and how. I don't know.
Sure, sure, sure. With athletics, one other question that kind of has come up to mind is with my civilian patients that I see a lot of patients having activity intolerance, and they were previously very active people and almost to the point of like a dysautonomia type of thing. Do we see the same kind of thing happening with athletes?
On occasion, we will. So
Okay.
this is one of the challenges of concussion. And as a friend of mine said, if you've seen one concussion, you've seen one concussion. And
Yeah.
because everybody sort of responds to it differently. And if somebody have repeat injuries, their first injury may not look like their second injury. So it is really taking each injury and each person case by case and kind of
Mhm.
helping them move through. Uh, we see this phenomena in athletes, kinesiophobia, where people are sort of unaware or afraid to move their body kind of in the
Mhm.
ways that they're used to because of the injury or fall, I shouldn't say because of, but following the injury. We actually just had data. I'm trying to think. We just published it out of the Care Consortium a couple of months ago, where football players with a concussion, once they return to their sport, have a significantly reduced head impact exposure relative to their peers who never had concussion. So
Mm.
there sort of becomes this self-imposed safety mechanism, if you will, where people don't want to hit with their head because they're afraid of another injury. There's also some literature around changes in motor control following concussion. So this idea that people that had concussions are more susceptible to ankle sprains and ACL injuries. And then somebody just published a paper on upper extremity injuries earlier this week. And it's this idea, you think about the brain controls everything in the body. That's all the autonomic functions, but it's also all the voluntary functions. So we are sort of thinking there might be these micro changes in how you perceive the information coming in through your foot, through your ankle, through your knee, and then how your muscles respond to that. And that when you're operating on the limits of kind of functional performance, it may not get it quite right, and then that opens you up to injury. That's sort of the theory. Nobody's quite knows it just yet, but that's kind of what they're thinking about.
Huh. Interesting. Interesting. Are there other things to consider when getting an athlete back into sports other than just their symptoms and things like that? Other recommendations that go along with that healing process?
Yeah. So symptoms are definitely the number one thing that we track,
Mm.
but there are a number of computer pen and paper tests for cognitive functioning. We want to do a motor control balance evaluation for individuals just to make sure they can do all of those things that are going to then be required of them when they get back out onto the field. So
Mhm.
an athlete, hey, I have zero symptoms and my cognitive performance is fine, but I can't stand on one leg and I'm a gymnast, right? So like things like that, we would want to make sure those are all normal and it's safe for them to go back at all levels.
Yeah.
And kind of this gets into the kinesiophobia idea. The
Mhm.
other thing that we take into account and it's thinking about the injury as a biopsychosocial injury, long word. So there's the
Mhm.
biology of the injury, the bio portion, the psychology of the injury. So we have some individuals that they have an injury and they sort of catastrophize it, make it worse than it actually is, and they tend to have slower recoveries. And then the social component, right? So what's my team telling me, my coach telling me, my friends and family telling me about the injury? Are they telling me it's time to hang it up or no, everything's going to be fine, you're going to come back? And so taking all of that into account as the athlete is progressing through the return to play process, and then when we're making that return to play decision.
Yeah, yeah. And then, so I'm big on lifestyle issues. So when I'm meeting with my patients in clinic, whether they were an athlete or not, we're talking about sleep, we're talking about nutrition. Any other recommendations from that standpoint that are or are not talked about in the recovery for athletes?
Yeah, I think you're doing the right thing. So there is definitely some early work on a supplement, specifically around creatine. There seems to be
Uh-huh.
a small effect there. There have been some recommendation around fish oils, although I haven't seen good data on that. I don't think it would hurt, but I'm not
Yeah,
positive it's going to help.
yeah,
Definitely sleep is going to be key. And really what we have some unpublished data here that we're working on and we're trying to get out so people can see it. But there seems to be a sweet spot with the sleep. So clearly
yeah.
sleeping too little, less than 6 hours is bad. But actually sleeping more than 9 hours has a very similar effect. It's almost bad for the person. So we want to keep them in that 7 to 9 hour sort of range. And that seems to be the sweet spot for recovery. It is okay to let somebody nap during the day, so long as it doesn't disrupt the sort of evening,
Yeah.
nighttime sleep cycle. So we just want to be, take a 30-minute nap, that's fine. Don't take a 3 hour nap and then you're going to be up until 1.
Yeah.
Nutrition is always good. I think we would recommend good nutrition for all athletes and everybody for that matter at all times.
Yeah.
But particularly in that post-injury, we want to stay away from alcohol, illicit drugs, other things that might interfere with that recovery process just as a whole. And, get a balanced diet, stay appropriately hydrated, and those types of things. So it's really kind of putting all the energy an athlete would put into kind of performing on the field. We now want them to put that energy into recovering from their injury so they can get back onto the field.
Hmm. Hmm. And then, so a lot of those athletes, when we're talking about collegiate level and below, they're in academics as well.
Mhm.
I think the last thing I saw was that we try to get them back into academics before we get them back into sports. Is that right?
Absolutely. So it's a similar progression that we would use to get somebody back onto the field that we would get them back into the classroom. So if we have a student athlete during the academic year, we give them relative rest for 2 days, 48 hours, and then we start to work them back into the classroom really on a 3-step protocol at that point. So I should say 4-step total. 48 hours of rest is step one. And then we're going to work them back into the classroom with some accommodations. So that might be extra time on homework, extra time on tests or other assignments. They might, if it's a high school student, they might need to leave the class a little bit early to give them more time to get through the hallway because multiple things kind of coming through the hallway simultaneously might disrupt them a little bit. They might need to take breaks in the middle of the day, particularly after challenging classes like language and math. And so just giving them some accommodations. Then we're going to work them back into kind of just amping up the materials. So they're doing homework, they're trying to work through a full day of school, and then we get them back unrestricted into the class. I think different from what we did in years past. It used to be school first and then back on the field. Now those two things can work at the same time. You can progress through return to learn and return to play at the same time. But they absolutely need to be back in the classroom 100% before they're back on the field unrestricted 100%. Because it doesn't make sense that Friday during the day, oh, I couldn't make it through the school day. I need to go home early, but we're going to put them back onto the field for Friday night football. It doesn't make sense to anybody. So
Yeah.
we want to make sure they're 100% in the classroom before they're 100% on the field.
Yeah. Yeah. Because what's the risk if we put them back on the field before they're healed?
Really the biggest thing is you're going to but there's two things that we sort of think about. For sure, we're definitely worried about another big impact that's going to just worsen the injury, right? So you can imagine you sprain your ankle and you're getting better, and you're like, I'm going to go play tennis today. And then you're just at greater risk of another injury and it's going to be worse than the first one. So we want to really
Yeah.
avoid that. The other thing that particularly we think about in our youth athletes is a condition called second impact syndrome. And this is where there's a second injury while the first one is still recovering and it causes this uncontrolled swelling in the brain. And you can imagine that the brain is a soft tissue. It sits inside of a bony box, our skull. And then as it swells, there's no place for it to go. So
Mhm.
there's actually a herniation that starts to push through the hole in the bottom of our skull where the brainstem sits, and the morbidity and mortality rates are just through the roof. This is absolute tragedy when this happens because the survival rates are so. So that's really what we're trying to avoid. Those are very rare, but they do
Mhm.
happen on occasion. But obviously,
Mhm.
we want to eliminate that and take it to zero.
Yeah. I've never actually seen it myself because it is so rare, but I've always wondered, now that we know that data, looking back at some of the athletes that have passed away on the field or shortly after coming off the field, if those might have been cases of second impact syndrome and just weren't identified correctly.
So there were the Center for Catastrophic Sport at University of North Carolina. They track it, and there are a handful of cases that happen every year. And so it was talked about a lot more in the early 2000s than today, but it unfortunately it still happens on occasion.
Mm, mm. You would think that with the new recommendations, if everyone's following them, that we wouldn't really be dealing with that anymore. Interesting.
Yeah, I mean, I do think medicine has gotten better, and we have
Yeah.
data to show that repeat concussions are going down or have gone down, but unfortunately, these tragedies do occur.
Yeah. Yeah. Unfortunate. Any interesting things that you've learned along the way in your time working in concussion?
Every day is sort of like a new interesting thing, so it'd be a long conversation, but, I think when I started with this in the late '90s, we were just trying to understand, like, what is concussion? And at that
Yeah.
time, there was a group or, a pretty substantial group that felt you had to have loss of consciousness. Then there was a study out of the University of Pittsburgh that said, no, you didn't, and loss of consciousness. Actually, back then, it was about 10% of all injuries. Now we think it's actually about 5% of all of the injuries. And so like that has changed. Evaluations went from how many fingers am I holding up and are you ready to go back in to now we have this very systematic approach of symptoms, a cognitive screening, balance tests. We have really standardized, thought out, well researched return to play protocols. And then really the thing that where the field has really shifted to are long-term effects. So
Yeah.
the injury identification and management will improve more. We are not done there, but I think we've made the biggest substantial gains have probably been made. I think
Mhm.
what is yet to be determined are what are the long-term effects. And it's clear that some people have challenges. It is less clear who has them and why they have them. And then once we have that, then we can start talking about innovation.
Yeah. Yeah. And the long term effects, that's where I practice every day.
Great.
Is seeing patients in follow up in the clinic. And I will say I have a whole lot less people that continue in follow up if they were very physically active, if they were injured in snowboarding or whatever activity that they were doing that they were very active all the time. They come back for follow up very little compared to the rest of my patients. So
Yeah.
we're doing something right with athletes.
For sure, I think there's a couple things going on there. One, they're motivated to get better, right? Because they're
Yeah.
like, I want to get back to my sport, whatever that happens to be. I think the other part, and there's some work by Sean Eagle at the University of Pittsburgh on this, and I'm just going to cast sort of a large stereotype here, but the high BMI individuals have slower
Mm,
recoveries than kind of the normal BMI individuals. And it sort of makes
interesting.
sense, right? So there's,
Yeah.
high BMI individuals are predisposed to metabolic syndrome and just systemic inflammation. And then you throw an injury on top of that, it just sort of makes sense. It's going to take them a little bit longer. So our sedentary individuals are sort of make sense that they're just taking longer based on kind of
Mhm.
lifestyle factors, lifestyle choices.
Mhm. Mhm. I think I'm gonna be encouraging my patients to exercise even more than I already do.
Movement is good for you for sure.
It is. It is. Where can people find you if they wanna learn more about the work that you guys are doing in your program?
Yeah, that'd be, I'd appreciate that. So they can learn about the Concussion Center here at the University of Michigan at concussion.umich.edu. And then I'm on LinkedIn under Steve Broglio. I'm the only one out there that I know of.
Yeah.
Those are probably the best two places. And, your audience is free to shoot me an email or message me on LinkedIn if they have a question.
Awesome, awesome. Any last words of wisdom, advice, anything that you'd like to share before we wrap up today?
Well, one, thank you for the conversation. Always fun to
Yeah.
have these chats. But, I think the idea that somebody has a concussion and then that predisposes them to some negative outcome in life, I think that's false.
Mm,
And, I think for the vast, vast majority of individuals, injuries that are identified and managed well, that person can recover and lead a very normal, healthy life with no challenges. And I think trying to keep that in mind, we want people to participate in sport, physical activity, rec sports, because we know running around is good for you, right? We just chatted
mhm.
about that, and there's risk to that, of course, and we can do things to minimize that risk. But the benefits of sitting, or I should say, the risks of sitting on the couch are very, very high. We know what happens
Yeah.
when you don't do anything. So I would rather people participate in sports safely with minimal risk for concussion than just sit on the couch and be with them.
Yeah. I think those are great words. Great words. So thank you so much for being here today, Steve.
Yeah, you bet. I appreciate the advice.
Thanks.
Thank you.
Thanks for tuning in to this episode of Brain Wellness, the podcast. If you enjoyed this episode, I encourage you to subscribe, like, leave a comment, and share it so that others can benefit. Please also consider supporting the show by buying me a coffee. The link is in the show notes. You can also go to www.brainwellnesssolutions.com to catch the latest info and get links on all of the social medias there. See you next time.